So this whole thing came about because over the past few conferences of the International Society, Professor Ganapathy and I have had huge disagreements about whether it's ICT for health or for healthcare, and it's expanded into whether ICT for health is a boon or a bane. And I'm going to speak to the proposition that ICT for health is a boon, and he will speak against it. So if you look at, I'll show a few slides just to illustrate my point. So let me move on to the first slide. It has to do with, there we go. This is a scatter plot on a log-log scale of all the countries who are members of WHO, 193 countries at the time. On the horizontal axis, you have GDP per capita, and on the vertical axis, you have spending on health per capita. Now, the statisticians and even the non-statisticians in the room will recognize that there's a very strong correlation between spending for health and GDP per capita. It makes intuitive sense. Countries spend on health in proportion to how much they make in the economy. Absolute sense. But, oops, where did that go? Okay, next slide. This is another scatter plot of the same countries. On the horizontal axis, you will see GDP per capita, which, as we've seen, is a proxy for spending on health. On the vertical axis, you have one of the key indicators for outcomes in health, which is under 5 mortality. You will see that there is no correlation between spending on health and health outcomes. I'll give you the case of 2 sets of countries, X and Y. Countries X and Y, they spend the same amount on health, but you see that in terms of health outcomes, one country is 60 points better than the other. And then another set of countries, A and B, they have the same very good outcomes, low infant mortality, under 5 mortality, but one country spends 10 times as much per capita as the other. That's the case of A and B. What accounts for this difference? 2 things, primarily. One is the use of technology, the other is good management. So technology can have a great influence on health outcomes if you use it correctly. Another example, just look at time spent. There was some discussion today as to discontinuity. The last speaker from Canada about the opportunities lost to capture data because people spend time entering the data. It makes the process discontinuous. This is a case of how much time is spent in 3 classic cases, a study done by PricewaterhouseCoopers and Libran. And it shows that in some activities, clinicians spend as much as 1 hour doing paperwork for every hour they spend next to the patient. What if we could relieve the physicians, the clinicians, of this paperwork by doing things digitally, electronically? Here's another statement. This time it's by R. Daniel Mazes at the Institute of Medicine, U.S. Institute of Medicine in 2001, and he says, current practice depends upon the clinical decision-making capacity and reliability of autonomous individual practitioners for classes of problems that routinely exceeds the bounds of unaided human cognition. It's a cry for help by clinicians that the decisions they need to make need all kinds of support, decision support tools in health, expert systems for clinical decision making. These are the kinds of tools that ICT for Health brings to support this cry. And you see that it's very necessary to support these clinicians, these health workers in general, because this is a map of all countries in the world that responded to this survey. The countries in red in 2006 are the countries, 53 of them around the world, which did not have a health workforce density sufficient to meet the MDGs, the health MDGs at the time. Unfortunately, most of these countries were in Africa, but you also see India there as one of the countries in red. Not enough health workforce density. That is doctors, pharmacists, nurses, midwives, etc., per 10,000 population. So something needs to be done. Traditional training, not particularly useful. From the example in Kenya of e-learning, where they wanted to upgrade 22,000 nurses to become registered nurses, they estimated and started on this project, were able to forecast that they'd be trained these nurses within a period of 5 years. It will cost them 1/10 of what it would cost if they used traditional methods for educational delivery. And even more important, if they did not use modern e-learning methods, they only used traditional methods, the time to upgrade those 22,000 nurses was estimated to be between 150 to 200 years. I don't think we have enough time to wait for that to happen. So, but my basic thesis is this, and it comes from the WHO Commission on the social determinants of health. And it says very clearly, and I'll look at it this way, reducing health inequalities, that's one of the key things, for the Commission is on social determinants and ethical imperative. Social injustice is killing people on a grand scale. The issue of inequities in health, and my thesis is that ICTs in health can help improve that. And the Commission recommends as follows: to improve the daily conditions in which people live, work, and play, and take the inequitable distribution of power, wealth, or tackle the inequitable distribution of health and power. So, digital health, however, is a two-edged sword. This statement is a very powerful statement in my mind. It says, you can read it yourself, that more people have access to mobile phones than to clean water, electricity, or toothbrushes. Now, based on the fact that our health is a product of everything that we do, and I mentioned specifically this morning areas like water and sanitation, yet we do not have access to those, or more people have access to mobile phones than to these basic water and sanitation elements. It therefore presents an opportunity to be able to do something using ICT, using the mobile phone. Secondly, that advances in technology redefine the ways people, systems, and information interact. Resource-poor communities are often excluded. It's a classic thing. Technology tends to raise average levels, but tends to increase the inequalities, inequities, I should say, among them. So, I couldn't resist putting up this slide, the same two statements, but look at that graphic, which greatly illustrates the difference between equality, equal treatment, and inequity, or in this case, equality and equity. If we want to be equitable, we want to produce equitable health outcomes, we must be forced in some circumstances to provide unequal treatment. It's a very powerful thing, and the ICT can help us get there. So, in summary then, we believe that digital health translates into opportunities. Opportunities not simply to digitize analog concepts, but to transform them. This conference, as Sangeeta pointed out, is a classic demonstration of the belief of most of you here that ICT is the way to transform health. But that should be based not only on health care, and this is where the disagreement with Professor Ganapathy started, but it should be broadened to health production as a whole. Our basic tenet being, therefore, that health is produced in the home. This is from a friend of mine, Francis Omaswa, who swears health is produced in the home and repaired in institutions. Okay? So we need to make the most we can out of ICT, because there are more opportunities for ICT in health, in producing health, than in curing diseases. I said that this morning, and I'll say it again, and really, that's the low-hanging fruit. Thank you for your attention.